amendment with us. All right, we're live. So Senate Health and Welfare, we're back. And we're looking at a proposed amendment on SH 766 that Senator Kitchell is bringing to us.
I don't know if I did even. Thank you, Madam Chair. I guess it was obvious from my comments on the floor the other day that I've tried to look at this issue. I've been hearing from people with strong views on either side and trying to figure out exactly what is a prudent path forward and what are the risks and who it would be impacted. And so it gets into the collateral issue around, well, ultimately, will there be an impact relative to plans that are purchased on the exchange, bronze plans, small insurance plans, and so forth. So there have been a lot of competing narratives in this building. And I know that certainly the issue around prior authorization is one that is fraught with strong feelings and emotion. And I know that one of the initiatives that this committee, I think, was involved in is the creation of the listening sessions. And one of the things that really emerged from the listening session was the impact that prior authorization requirements have on our primary care docs. And that was really something that was very much a part of your presentation of the bill. And so what I'm proposing here is perhaps a more incremental approach, and that is providing the relief to the providers that are the least, the most burdened, and the ones that we rely on the most in terms of the provision of healthcare, many of them for our poorer and more complex or sicker Vermonters. So what I was doing here is saying, let's, rather than making it sort of all inclusive, to start out with providing the kind of relief that seemed to be warranted and more strategic toward that group of providers. I guess some of the concerns stem from not only the testimony of Mike Fisher, everybody's trying to balance out where, who gains, who does not. And so one of the things that I started to think about is to what extent 90% are approved, 10% are not. That would suggest that 10%, I don't know what that 10% represents. It could be some of the higher cost ones that could be approved, but it's approved, but recommending a lower cost intervention. I know from years with the Medicaid program that certainly the low level of reimbursement is a financial deterrent to any kind of you're not going to, you generally are very cautious when you're dealing with a reimbursement system that oftentimes you view it shifts costs to others. And I made reference to a book the other day, why too much healthcare is making us sicker and poorer, but there's another book here, and actually Elizabeth Bradley came to Vermont.
She did.
Yes, and believe it or not, it was in April of 2015, which
We're still working on it.
And but one of the things here that really struck me is here, healthcare providers, all kinds of medical services organizations, and the patients as well contribute to the medicalization of America on account of their sometimes misplaced faith in specialty care, medical technology, and the newest medications. Concrete cases from patients and physicians that were interviewed illustrate how various actors may exert power to increase the use of expensive medical care without commensurate improvement in health. And so there's another story is where the medical environment can influence patients to opt for more medical care than they might otherwise have chosen. And we certainly have seen that with end of life decisions in terms of what people would want versus what maybe in the end is prescribed. So with all that and knowing the dynamics at work, knowing that we talk about fee for service, and that is a perverse methodology because the more services you provide, the more reimbursement you get. And I know that hospitals would love to be relieved of this, but they won't be relieved of it. The irony is the hospitals themselves, their healthcare plans, in fact, would be exempt from this prior authorization. At least that's what I've been told. So that's kind of an interesting turn of events because, as I mentioned, we have here in Vermont, I asked for it, the self-funded health plans that are would not be regulated and this provision would not apply. So the interesting thing is, for example, UVMMC would have an MVP patient from New York, and the prior authorization requirement would be in place. But a Vermont MVP subscriber would not have it apply. So the extent to which this will provide the kind of relief is, I guess, yet to be determined. And so I've been around long enough to know that sometimes we have impacts that can perhaps not be what we would really like. And so I thought it would be perhaps more prudent to start out in a more strategic way and focus the exemption from this authorization to the primary care services that we have. The other thing, we talk about it, we talk about Mission Creek, but the extent of relief versus the extent to which, whether you have to apply, whether you have to go through a prior authorization request, or if you're relieved of it, the extent to which that serves as sort of a dampering, or I don't mean it in a negative way, but it's sort of like, well, if I have to do this, I gotta go through prior auth, but if I provide this kind of treatment, I don't. And I think obviously knowing human behavior, we tend to want to go, with the most time efficient, less labor intensive. So I don't know the extent to which this, in fact, by relieving or changing this policy around prior authorization would result in that sort of practice creep. And for the extent to which MVP would even at some point not view Vermont as an attractive market, which we do need competition. So those are all the things that have been rattling around in my brain as I've considered this. And on the surface, you look at these very compelling stories, some of those stories, in fact, could be with the insurers that won't even be covered by this prior auth exemption. It seems with the potential impact, and I calculated it out, not that anybody cares so much about necessarily the state of Vermont healthcare costs, but we've heard 1%, 3%, pick your percent, but I started out with 1%. So if 1% is true, then we're talking about $3.5 million in addition to the normal increase that we're experiencing. And that would apply obviously to teachers' plans as well. So if it's 2%, then we're talking about $7 million. So that just shows on this side, but the part that I'm really concerned about would be on the market and on the premium burden that we already know some of our lower income Vermonters are experiencing now in the marketplace, and they're moving down to the cheaper plans with higher deductibles and higher out-of-pocket costs, and the economic burden that they are experiencing now, and the extent to which this perhaps could exacerbate that downward or upward trajectory in terms of premium burden. So that is why I came to this conclusion that that maybe from a fiscal perspective, trying to minimize what might be yet unknown impacts to be strategic and say, let's relieve this burden. I was talking to someone just a couple days ago. Son-in-law is a primary care doc in in an urban clinic serving really difficult poor people. Brother-in-law who's a specialist, and just the difference of opinion in terms of, their experience in the healthcare and the nature of their work and the compensation and the administrative burden. So, it's with all that I have come up with, it's like not postpone anything. It's simply saying, if you want to talk about step therapy, I guess maybe this is the variation on that concept. Starting with where the relief is most needed and would have a significant benefit and would help address the very legitimate concerns that have been articulated by the primary care providers in the state. So that's what my amendment would do.
It would.
Simply,
Yes, so just go, when we'll have Jen
Yeah.
help going through your amendment.
Yeah, sure.
It will be complicated.
And you will notice, as she goes through it, and I really don't know. We've heard how much money and how many people are having to be employed in our healthcare delivery system as a result of prior authorization. If in fact there is that much of a burden and that much economic relief would be experienced, then I would like to be able to recapture it and define it and say it goes to premium relief, because those costs are already embedded in our system right now. And if in fact we think this is a strategy that should reduce it, then who should benefit? Should it fall to somebody's bottom line, or should it fall to the benefit of the payers? And I know that this committee, spends some time on insurance, but certainly insurers, there are a lot of negative attitudes toward insurance. Our Blue Cross Blue Shield plan is nonprofit, and we know they're not in great shape. It's not as though they're for profit and they're rolling in dough. Their reserves have been eroding, and so if their ability to absorb this, it will just simply.
We get it. No, we understand. We understand that there are dire straits across the board. It's not just, it's not just providers, it's not just payers. And we also understand that there are pressures put on payers and on providers. Our interest in this committee continues to be primary care. So I appreciate what you're saying about primary care and the work that we've done to improve payment and quality metric analysis, which is something in here that we're constantly talking about. How do you know you're getting the bang for the buck? I mean, that's a big one. So I appreciate the thought that you've put into this and brought to us. And I think it would be helpful for us, just because we're in a crunch.
I know that.
I've got 100 bills we're looking at right now that are driving us.
Yes, and I apologize. I've been so
don't
busy with the
apologize.
state budget.
No, don't apologize. What we're gonna have is we'll have Jen come up,
Yes.
go through your proposal and see how it fits with 766. Because, as we presented our bill, it was very much about the pressures being put on primary care and losing those physicians. And I think people heard that. Obviously, you heard it. So,
Well, I've been hearing it for a long time,
yeah,
and so I think it would provide relief, particularly to our FDCs
absolutely.
and to our primary care. So, all right, I'll
Let's have Jen go through, and then we'll go to questions for the committee.
okay.
Good morning, Jen Harvey from the Office of Legislative Counsel. So I will put the language up on the screen. This is an amendment to H 766 and has two instances. The first is in section 3, which is the section that requires alignment of prior authorization requirements in health insurance with those in the Medicaid program. And so I tried to put the differences from the bill that you considered and approved in this committee. Those are highlighted in yellow. So it keeps language talking about the intent of the General Assembly to reduce variability by aligning the prior authorization requirements, but it specifies for primary care providers to the greatest extent possible with the prior authorization requirements in Vermont's Medicaid program. And then it uses as the definition of primary care provider, the same meaning as is used by the Vermont Blueprint for Health, which I think has done a lot of work in identifying what constitutes primary care and who delivers it. And then it would say that a health plan shall not impose any prior authorization requirement for any admission item, service, treatment, or procedure, and it would add ordered by a primary care provider that is more restrictive than the prior authorization requirements that DIVA would apply for the same admission item, service, treatment, or procedure ordered by any provider. I don't know that Medicaid specifically identifies or differentiates between provider who's ordering in the Medicaid program. So just to try to avoid confusion there. And then I've left in the rest of the language in that section. So it still requires plans to review prior authorization requirements in Medicaid at least once every 6 months to make sure they're requiring that alignment and maintaining that alignment. And then it continues to carve out or exclude alignment with for prescription drugs or anything not covered by Vermont Medicaid. Continues to allow prior authorization for anything provided out of network, and it continues to specify it does not require maintaining the same provider network as Medicaid. The second instance of amendment would add a new section, and this would be amending the hospital budget review statute and adding to the list of what the Green Mountain Care Board considers in conjunction with hospital budget reviews, and a new number 14, that the board would require each hospital that delivers primary care services to report on the amount of savings or avoided costs that the hospital realized as a result of the limitations on prior authorization requirements for primary care providers pursuant to that section we just looked at, 94.
But the word limitations, why is that the limitations on front? Oh,
Because that's what happens up here is that
no, I understand. So I'm wondering why the word limitations is used there. If we're eliminating, overall, we're eliminating prior
you're
authorization.
not eliminating, you're aligning with what Medicaid requires for prior authorization. So it's not an elimination. I viewed it as a limitation. We could use a different word, but I think there's been a lot of talk about whether it eliminates or doesn't eliminate. It aligns with Medicaid.
Okay.
That's it.
And so it asks the hospitals, how will the hospitals know? How will the hospitals gather that data? Okay, what is your, I'm thinking of that.
I had an opportunity to speak with Susan Merritt, Green Mountain Care Board,
I figured.
and last night, so you can see the time right here. And she said they are able to capture that data, to have it recorded as part of that hospital budgeting process.
So the question is, what additional cost or burden does it place on the hospital to collect that data?
They have it now, they know, obviously, because they're having to fund the administrative costs associated with the prior authorization.
Right, so I'm gonna turn to the hospital association. Are you in concurrence with that comment?
Sure, Devin Green, Vermont Association of Hospitals, or of Hospitals and Health Systems. I think it depends on what is at it. So we do have costs associated with prior authorizations. It may be difficult to figure out the alignment to Medicaid versus not aligned to Medicaid piece. I guess we could look at variation from year to year. So it's something we could work on. It would certainly be easier if there were no prior authorizations to compare.
All right, so looking at the language that's there, I'm trying to figure out, so the language that, let's go up to the first part first. There we are. So, aligning with Medicaid, for primary care is taking this step, which is less inclusive than what we currently have in the bill, but it would get at the information that we're looking for. I'm just talking about committee, right?
Right.
So
I don't know what
comments
you-
on this section.
On the first section.
Yes.
Provider review.
I'm. Sorry, I was just trying to figure out the reporting thing, because it doesn't,
Now,
What makes
before we
sense
get
to
to the
me, but-
reporting thing, that's a little, that might be. Wait, here's what I'm thinking. Now, let me just say what I'm thinking. I'm thinking, if we did this and as a step forward, it might ameliorate some of the concerns that we're hearing about the bill. I'm wondering if the committee could agree with this section of the amendment. And we might want to join in presenting this amendment from the committee. So that's one question that we have. Then the second part is the reporting part, and that, you know, that might entail, we don't know, we're asking what it would entail to get that information. So we know that the board can ask for it, and the board believes that they can get it from the budget process, but that doesn't tell us what the administrative burden might be on the hospitals to provide that information. It's two different questions. Oh, that's the second question, about how do we discriminate? How do the hospitals discriminate primary care provider prior auth, lack thereof, and the effect on the hospital services? We already have in the bill a reporting. And so we could leave that section open and allow for that to be negotiated, discussed between the hospital and the board. Because I see that putting that in becomes another problem statement that may offer administrative difficulty. And I see you shaking your head, so.
I agree.
Yeah.
14 becomes less important if you're really saying as a first step, we're doing the primary care.
I agree.
If you want to have them more inclusive, then I would argue that absolutely, because we're having a much wider net and a much wider impact.
Right, and
so-
that was the intent of the
so-
report, to capture
Yeah,
everything
yeah.
that you've
So,
clarified.
I would just simply say that, by, the more strategic approach and trying to provide relief, administrative, relief to that sector of providers, provides much less risk than the whole thing. So I would say 14, is not as important. If in fact the decision is, no, we just want to go whole hog, then I would argue very much. And I have another amendment, that would do that.
She's got several back pockets.
So I just want to say, I don't think the importance of 14, if we're really talking about primary care and the relief that we want to provide to that segment of providers, is
Yeah.
that the study would be sufficient. Is what
Okay, so,
I would say.
so let's do that. Okay, so let's take that one. Let's take that one out for now, and then we'll focus on this one. And I will say, if we were gonna put that section of report in, we might want also to include the payers in that and what staff they might be saving as a result of that. But that gets a little bit into the
You
weeds.
do still have them, I mean, you
And we
do
still
still
have
have
the
the impact
reports.
reports,
Yeah, we have
the
the-
payer, the insurer, and
Yeah.
the provider impact reports.
Okay, so on this, Senator Hardy.
Yeah, I mean, I first appreciate your attempts to try to find something to move forward with. I am most concerned about primary care providers. I guess in order for me to feel comfortable joining on to this amendment, I would prefer that it would just be, if we're just gonna focus on primary care, that we try to provide the greatest amount of relief possible, and just to say, you know, that they are exempt from all prior authorization, and that I mean, that's really the focus, is to say,
Yeah.
we're trying to relieve them from prior authorization And we, you know, and the other
Well, that's-
providers can stay in the current regime, and primary care would be in just no prior authorization regime instead of even aligning to Medicaid, because I am concerned about the confusion, you know, and that would, I would feel comfortable with that.
that's where I was going with that, one too. So and if we did that, we could do that perhaps as take out that report and do it as a committee proposal and along with Senator Kitchell.
I have no pride of anything. I'm just trying to.
Could we, would you be interested in if we did that? I think the committee, it would help the committee make that step forward. And it would also give us the information that we need in that reporting process. And it would also relieve the pressures that we're seeing both on primary care and also on the payers with respect to.
I don't know, basically you'd have a dual track, because then you're saying, Medicaid could in fact have some prior author, and what you're saying is those would not lie, if I understand.
Correct, yeah, so that the primary care providers
Yeah.
would not have prior authorizations.
Yeah.
Other providers would.
It'd still be under the same regime they're currently under.
Right. So
Committee.
let me see how that works for primary care.
Well, and that's the step that Senator Kitchell is suggesting. And so I'm in agreement, but I would agree with that. I don't know how the rest of the committee.
I agree with it too, and if I could just say one thing, I appreciated the quote that Senator Kitchell brought to us from the book. It made me wonder though, how much of sort of overprescribing would be captured, by pre-authorization. And the reason I bring that up is very quick personal anecdote. When I had tendonitis, years ago, the doctor just said, you know what, we're gonna do surgery. And that was authorized. It was, you know, everyone was fine with that. I was the one who stepped out of our culture of over prescribing treatment and said, I don't, surgery, is there another option? And yeah, there was another option. I could wear, you know, a brace and it healed over time. So I hear what she's saying, and yet I wonder how much of that is just the culture of the system that we have, as opposed to like prior authorization or not.
That's a good question, and that's one of the reasons why fee for service, we're trying to move from fee for service, so that overutilization and higher utilization is problematic. Oh, so she's gonna read us another quote.
No. It's like reading.
It's good reading.
I have, being Wardle in there, if anybody wants that,
So here's what I'm gonna ask the committee, can we have Jen draft us something up that has well, we talked about, I haven't heard from Senator Weeks or Senator Williams on this. Okay.
Yeah, so I'll remain where I was when this bill was first introduced. I don't feel that we fully understand economic impact here. I don't think we even have an arm in the government that's supporting the legislators to allow us to do that type of analysis. Our sessions are too brief. We've got this after crossover, and we don't have a deep dive that compares those positions from both sides. I do understand the prior authorization conundrum. Yeah, it's I agree fully with, you know, I'm a patient too, family's patient too. I get that, but the financial analysis is the only thing that's going to convince me otherwise. I think we'll
get
ninth
there.
hour, and so I like the amendment.
Well, that's what we're talking about. What I'm gonna ask of Jen. And I understand your thought. Let me just say this, okay? It takes years to get fully engaged and understand fully. And so what we're relying on is there's the testimony that we've heard and the people in the room who have greater understanding and have experience with this. So sometimes it gets down to that. And I do understand your concerns, Senator. You've expressed them freely and fully. I do
My
understand.
real concern is advocates are paid to represent physicians. We need an impartial analysis of this issue. That's what I'm saying, not I fully respect everybody's opinion, but
And it's hard because we get, that's what happens in this world, in the democracy. It is the sausage making process. And you get a piece here and a piece there and ultimately it comes together and may not be the sausage you wanted in the first place. But if it's Italian sausage, I'll take it.
Thank you. I need to be an honorary member of this committee.
You are, you've always been.
Back in the COVID days when they were putting together all that big bill. I'm assuming the medications, I'm really concerned, obviously.
Oh, out of
that's-
network and medication.
You're not,
Yeah,
because
no, we're not
the introducing of
Yeah,
the
those are
biologics.
exactly the
others-
clarifying
Yeah,
questions.
All right, I
I
just
want
need
to
to be very
understand.
clear.
The out of network
Okay.
medical,
Right,
that needs to.
so it seems like a lot of the language in the first part comes out. Because we're not talking about aligning, it's just gonna say a plan shall not impose any prior authorization requirement for, that is ordered by a primary care provider, using the same definition. And then, so we don't need to have them review Medicaid, but do you still want to say doesn't apply to prescription drugs?
Yes,
We don't need to talk about what is or isn't covered by Vermont Medicaid, and do you still want to say it doesn't apply to out of network?
yes.
Okay, and then I don't think we need D, so my thought would be then that we carve out prescription drugs and out of network. We specify no prior authorization for the rest of the things ordered by a primary care provider.
That'll work.
And primary care provider uses the blueprint definition.
And so then my question is this. This will be a proposed amendment. that
You can take it, I have no pride about it.
I'd love to have your name on it as our ex officio member.
Yeah,
Well, it's okay.
it's fine.
Okay, and then members of the committee, if you wish to sign on, just raise your hand. Okay.
Come on, Terry, you said you want.
Yes. So Senator Mitchell is taking your.
that's, you're an alumni, right? Yeah.
Oh, she's, we
Just
made
about
her an
everything.
honorary,
And who will be presenting?
well, Senator Mitchell will speak to it, I'll speak to it. I can present it.
All right,
Senator Kitchell is
So I'll
gonna,
put your name first, that's fine.
that's fine.
that would be helpful, but I'm gonna rely on you to present the information that.
You want me to quote?
Oh, yeah, definitely, with permission.
Oh, yeah, sorry.
All right.
Thank you.
Thank you. All right, thank you very much, Senator. It's extremely helpful in time of stress to have your help. We appreciate it.
Thank you.
Agenda, oh no, you can go.
We need something.
You can't wait, I have one more amendment.
Oh.
I wanna know if you wanna sign on to this. This is the language.
Yeah.
This is the language. I think I took it up. I don't think I took it upstairs yet. On the little paragraph.
You want me to put it up, this up on
The
the.
asthma language, did I take it upstairs?
I don't
I don't think
know.
so. I
Do you want
want
me
to show the committee first,
Do you want me to put it up on the screen?
please. And this is the language that never we asked VMS and providers to we had language in there that had age in, and it was contrary. DFR informed through a letter to the entire Senate that it was contrary to statute. So I was surprised to find that because we hadn't heard from them, but here it is. Kind of a different way to get information. So which is another democratic process. So this language speaks the threshold, so it doesn't violate federal law. Is that right?
Yeah, so this takes out references to particular ages, which DFR reminded us is considered discriminatory under the federal law and not permissible.
I think this looks great. I'm
Okay.
happy to
Do
comment.
you want to sign on? Who wants to sign on? Just raise your hand, please. Okay, everybody.
Okay, great. And the rest on, and I will get,
Yes.
so I'll do this.
All right. Now, we're way behind. Oh, I need to.
I need, yeah.
We need to